Okay, this is the second video for the digestive system. We're continuing from slide 53. We're talking about GE reflux disease or GERD. Um, GE standing for the gastroesophageal part of the system. Um, so we can talk about the reflux of acids and pepsin from the stomach towards the esophagus. We can talk about the decrease in mechanical pressure in one part of the system, which lowers the resistance, whereas the increase of mechanical pressure in the lower parts of the system create a gradient where movement is favored upwards. Okay. Um, and acids are supposed to be buffered, and sphincter tone is supposed to be restored under normal condition. We see that physiological reflux is asymptomatic. Now we can look at the idea of erosions. Erosions um, are the mechanical outcome of mechanical, or the biological, sorry, outcome of mechanical pressure, whereas those forces cut into the environment, and then obviously there's a good chance that they're going to hit blood vessels. So when we're talking about non-erosive reflux NERD, um, that is not one of the symptoms that we expect versus erosive reflux. So the person in NERD has the same symptoms as GERD, with no visual esophageal mucosal injury because there's no erosions. Um, an inflammatory response may result, leading to reflux esophagitis, obviously. Um, So as we said, the distension, sorry, of one area, meaning the decrease in mechanical forces, influences the gradient in such a way that allows suddenly content to go to places, to arrive at places it shouldn't go, and that is the reflux itself. Um, you can see that symptoms include obviously the reflux itself, heartburn, acid regurgitation, meaning it's going upwards, dysphagia, chronic cough, asthma attacks, laryngitis, and upper abdominal pain about that appears 1 hour after eating. Obviously, you need to eat and digest the food first in order to apply pressure and cause the symptoms. You can see that lying down and increased abdominal mechanical pressure worsens the symptoms, because instead of standing upwards where things are supposed to go downwards, you're lying back, and that increases the pressure on the stomach. You can see that edema, obviously, when you have a mechanical pressure difference, it's going to change the mechanical gradients of fluids as well. So edema is one of the options. Strictures, spasms, and decreased motility um, are leading causes of dysphagia and weight loss as well. Then we can talk about hernias. Hernias are a protrusion um, of the upper part of the stomach. It is as if you were creating a mechanical crack in the tissue of the area that you're looking at. In this case, we're talking about the diaphragm, and that is one of the muscles you don't want to mess with. It has multiple influences on the digestive system, on the respiratory system, and on metabolism. You can see that in this case, the stomach goes upwards, pushing the diaphragm into the thorax area, and that's going to increase pressure on the lungs. Then you can see the two subtypes that exist: the sliding hiatal hernia the more common one, where you can see that the stomach slides into the thoracic cavity through the esophageal hiatus, and this situation can worsen if you have a short esophagus due to either from birth, trauma, or weakening of respiratory muscles. You can see coughing, bending, tight clothing, accumulations of fluids in the cavity, causing anything that causes abdominal swelling. Obesity and pregnancy are going to worsen the symptoms, as I've said. Then you have paraesophageal hiatal hernia, is the hernia of the greater curvature of the stomach. Then you can see that it goes through a secondary opening through the diaphragm, lying alongside the esophagus. If you happen to want to understand exactly what's going on, I suggest that you open an anatomical atlas and see exactly where that would put the greater curvature, and you'll understand that that's not a nice situation to start with. So you see symptoms include congestion of mucosal blood flow, resulting in gastritis and ulcers. Strangulation of the hernia is a multiple complication, meaning that the mechanical pressure is so great that you're literally closing down the area, and that will worsen stuff. You see that both types seem to tend to be secondary to some kind of severe condition or disease. So to start with, you already have one condition or disease, and this is making it worse. They might be symptomatic at first and slowly over years become symptomatic. By the way, that means two things that we already talked about in prior units. One, on the one hand, it gives you more years to find it out. To if you go regularly to your physician, you can diagnose it and find it early. The bad part is that because it's asymptomatic, most people won't go to the doctor until they are symptomatic, and that means that it might be caught when it's too late. Gastroparesis is a delayed emptying with the absence of gastric mechanical obstruction, meaning that you're not delayed because there's an obstruction in the system. It's most likely something neural. Then you see that it has a high prevalence in people with diabetes mellitus, which also infects the nervous system, as you know by now. We believe that it involves the autonomic nervous system that affects smooth muscles, enteric neurons, and GI hormones. So it's completely functional in this case. You can see that there is a diabetic form, there's an idiopathic form, and there's a post-surgical form, which all of them, I believe, are self-explanatory at this point. Then we can talk about pyloric obstruction, or what we call gastric outlet obstruction. I think that the word obstruction should already explain to you almost everything. We've dealt with so many different kinds of obstructions. Obviously, it's going to divide the process to above the obstruction and below. Obviously, the extent of the obstruction is going to be a major influencer. In this case, pressure, mechanical pressure, is going to accumulate above the obstruction or before the obstruction when you look at the direction of flow or movement, and lower the pressure underneath it. If it's untreated, things get worse. You can have elevated mechanical pressure on the upper side or before the obstruction, influencing the environment or the neighboring tissues, and underneath it, the lack of mechanical pressure may lead to atrophy according to the principle of stimulus response. So you see it's defined as the narrowing or the blocking of the opening between the stomach and the duodenum. It can be acquired or from birth. Um, the acquired form is due to peptic ulcers, disease, or cancer near the pylorus. Obviously, inflammation, edema, spasm, fibrosis, scarring, and tumors are all possible causes of the obstruction. Nothing new here. So you see that symptoms may include vague epigastric fullness that worsens after eating or at night, nausea, and pain. You see that the pain is supposed to disappear, or symptoms, sorry, disappear, including the pain, once the digestive solutions overcome the obstruction. Anorexia can develop if the obstruction progresses, and in severe cases, they can cause distension and atony, leading to atrophy um, of the tissues and the organs. Um, then you can see that the mechanical rolling of the abdomen, which is a manual maneuver, produces the succession splash sounds accompanied by vomiting. So that's basically, if you think about it, that's fluids moving around the system that are splashed. You're supposed to be able to hear it. And then you have vomiting, and that is one of the possible indications of a problem that you could diagnose without going inwards into the body. So uh, in a it's an indirect, non-invasive way of diagnosing. These are, of course, signs of advanced obstruction, which is worse. Mistreated for long, it will lead to deficiencies of fluids and electrolytes. You already know the outcomes of those. And you can see that your stools are infrequent and small. Then we can talk about intestinal obstruction. Once again, same ideas are going to reoccur again and again and again. I won't repeat all of them. So abnormal flow through the intestinal lumen, either the small or the large one. Um, Obviously, the smaller intestine or lumen is easier to obstruct. Um, the classifications are of simple or functional obstruction. A simple obstruction is defined as the mechanical obstruction due to a lesion and is very common. A functional obstruction, also defined as a paralytic one, is usually due to surgery. Okay. You can see that adhesions and hernias are the causes of acute obstructions. Chronic obstructions are usually due to tumors and inflammation of the large intestine. Um, and then you can see that post-operation, the nervous system activates a set of reflexes that, combined with medication, may cause this condition as well. The higher the obstruction in the system, the more alkalosis will develop, and vice versa. Um, the difference between the two in the height or the location um, of the process in the system is that the anatomically higher cells have a higher tendency to use ions that will lead to alkalosis, and vice versa in the lower cells. Of course, in both cases, if you have an abnormality, you have a metabolic disorder or imbalance that will affect the surrounding and also affect the nervous system in some cases. Um, you have gas volumes that are increasing, that by definition are increasing mechanical pressure, which might occlude the passage within the system. If it's high enough, if that mechanical pressure is high enough, it's going to push on the surroundings enough to block or occlude uh, blood vessels that will lead to ischemia, and if worse enough, even to anoxia in that area, resulting in necrosis, elevated blood viscosity, changes to cardiovascular function, and you know where this is going uh, from there. And of course, little by little, as the symptoms worsen, the conditions for cancer and infections to be produced or induced become greater. Um, if it's untreated, pain becomes constant instead of appearing in waves. So that's a worse sign of the situation. And then if you have the worse things get, the color of what you're vomiting is going to change according to the content. The more tissue that is involved because it's getting worse, the more it will become yellow and green. Inflammation, gastritis, can be acute or chronic. It's an inflammatory disorder of the gastric mucosa, so of the membranes. You can see that it affects mainly the fundus and the antrum. Uh, the acute form is more superficial in nature and is usually due to injury of the mucosal barrier um, as a result of chemicals or drugs. So it's more at the chemical level of injury than the mechanical. You see that symptoms include vague discomfort, epigastric tenderness, and bleeding. You see that the chronic form is more common in the elderly, resulting in thinner mucosal layers. Then you have the type A, the type B, or the combinations of A and B. And I think that um, it's very simple to understand, two different locations or in both. Going into those two options a bit more, not too much, we see that the fundal form is the more severe form and has an autoimmune disease background. And you can see that it's also an atrophic um, form, meaning that it might cause the loss of mass. Um, then you see that it leads to the degeneration of the mucosa membranes, decreased secretion, uh, loss of feedback mechanism, elevated plasma gastrin, so you're changing the content of the blood, leading to anemia, which obviously is going to affect oxygenation. You see that we have malabsorption of B12, uh, and of course, possible outcomes include cancer. Then in the antral form, uh, this is the more common um, form between the two, um, more due to bacteria and is associated with alcohol and tobacco use. Once again, chemical for the most part. Um, Obviously, this type increases even more the chances for gastric cancer. You see that symptoms may include anorexia, fullness, nausea, vomiting, pain, inflammation, atrophy, and B12 deficiency. Continuing to slide 83, peptic ulcer disease. So we see that an ulcer is a break in the mucosal protective layer of the esophagus, stomach, and or duodenum. So any one of the three and any combination of the three. Um, the ulcer is the balance, in this case with a negative implication between the amount of mucus production and erosion. Um, Most of the process is still idiopathic, besides that it, in regards to the Zollinger Ellison syndrome, whereas the ulcers are caused by excess gastric acid secretion, which is part of the overactivity of tumors. So besides when it's from those kind of tumors, the process is idiopathic, and we still need to identify the exact process there. So you can have a single ulcer, multiple ulcers. They could be acute, they can be chronic, they can be deep when you look anatomically, or they can be superficial and multiple combinations. So superficial erosions are called superficial ulcers, are called erosions, while deep ulcers are called true ulcers. Obviously, the deeper the ulcer is, meaning a true ulcer, uh, it's going to cause damage to blood vessels and lead to hemorrhage, which once again has greater effects than a superficial one. I didn't find any reason to go over the ulcers according to location. I think that the idea is more important than analyzing each one of the locations accordingly. Then you can see that we have a stress-related form known as stress ulcer. It is the acute form of a peptic ulcer, usually accompanying some kind of severe illness. So it's secondary, obviously. It can be systemic or due to systemic trauma and neural injury. You can see that there is an emotional stress component that might accompany it. Um, any part or any combination of all of the above. Um, Usually they are either ischemic or what we call Cushing subtypes. Um, you can see that the ischemic ulcer develops within hours due to loss of blood or blood flow for any reason possible, and you should have a list in your mind right now of all of the causes. Uh, you see that curling ulcers are the specific results of burns. So you are burned, and that leads to an ulcer. When it's associated with head trauma or severe head trauma and or surgeries, they are called Cushing ulcers. Um, and the major symptom is bleeding. Uh, okay, a bit about malabsorption syndromes. Um, I think it's a pretty simple idea. Any cause that will lead to uh, decreased absorption of substances and nutrients will cause a malabsorption syndrome or will be part of it. So you see these syndromes decrease or prevent the absorption of substances into the body or back into the body. So retention. They're divided to maldigestion and malabsorption disorders. Obviously, maldigestion as a process precedes malabsorption. You have to digest it in order for it to be absorbed. Um, they are connected and often occur at the same time. So you see that maldigestion is usually a problem with digestive enzymes, either their number or their function. Um, and the absorption is more regarding the tissues that are supposed to absorb it throughout the system. Uh, these disorders can cause and worsen diarrhea. And we're not going to start going into each and every one of them. I thought that they were uh, pretty simple to understand. Okay, so on slide 92, we're talking about inflammatory Bowel diseases, better known as one of or two, either UC or CD, so ulcerative colitis or Crohn disease. You probably know about Crohn disease more than UC. They are complex, idiopathic, chronic inflammatory diseases of the bowel, IBDs in for short. Uh, the difference between the two is actually mainly the location and the symptoms due to the nature of changes to the cells. The pathogenesis in both of them is pretty similar in most cases. So if we talk about UC, you can see that it's a chronic inflammatory disease that affects the colonic mucosa in the rectum and sigmoid colon. Um, there's plenty of data to um, support a genetic mechanism of inheritance. Um, then you can see that we have humoral immunologic factors, especially the Th2 response and activation of macrophages are associated. So it's affecting the immune system. And you can see that it's commonly accompanied by an autoimmune disease, which is not surprising. It's progressive. It can spread to other areas such as the intestine and other areas of the colon. You have small erosions that turn into ulcers with time, and with the lack of treatment, you can it can result in edema and thickening of the mucosa. When you have a thickening of the mucosa, it decreases or impairs its function. This in turn is going to narrow the lumen. So if you have the lumen, like this, and you have secretions here that are becoming thicker and thicker inwards, then the available space for movement is decreased. Then you have um, cell injury that causes bleeding and mucosal destruction or the destruction of the mucosa membranes. Symptoms can include cramping pain, defecate urge, frequent and watery diarrhea, blood in the stools. Uh, it comes and goes, so waves of these symptoms might cause fever. It's an inflammatory disease, so fever should be in the list. Elevated heart rate, dehydration, weight loss, and anemia. Then you can see that complications in severe cases will include anal fissures, hemorrhoids, fibrosis, scarring, stricture, perforations, lesions, polyarthritis, episcleritis, liver disorders, coagulation disorders, and abscesses. Fun, lots of fun. Of course not. Those are horrible things to have and not funny. So the good thing is that people usually feel things in their stomach relatively easy. Okay, Crohn disease um, is an inflammatory disease affecting the intestines. Um, it's sometimes hard to differentiate between UC because they're very similar. But you can see that with Crohn disease, the rectum is usually not involved, usually, not always. The background and mechanisms are similar. Um, you can see that at the cellular level, the activators are different, so different enzymes, different pathways. Um, you can see that it tends to spread at a more extensive and provokes the immune system to a greater scale. So the immune response is worse in this case. Um, you can see that if you were to look at it under a microscope or some kind of visual way, you'd see that the lesions skip, so they're not uh, uh, um, continuous. They skip areas in between, and they have gaps in between. You can also see that it's going to they might affect the lesions might affect lymphoid tissue as well. The lesions are firmer and penetrate deeper into the surroundings, meaning that you have an elevated risk of hemorrhage. So you see that symptoms are the same, but might be delayed for up to several years, and the absorption disorders are more severe and extensive in CD compared to UC. Okay, I'm gonna stop here, and we'll continue from slide 102 in our third video.